to sketch out some stuff about health literacy, and initially started at a kind of population level. What's the size of the issue from a national level, and then move it down to my experience of health literacy, which is within the medical setting, and then move it beyond that and back out into the community and people's lives, and how in fact I think that is the most important thing, and that's where people like you have got the skills to help us to take this forward. So just to start off by reminding ourselves that this is about health rather than illness, and this is the World Health Organization definition of health. So it's not just about not being sick, it's actually about being well mentally, physically and socially, and that's what we should all be trying to do, and play our parts in supporting people to create for themselves. And the health service has got a part to play, but also the lifelong community, learning community has, I think, at least as big, if not bigger part to play. So that's the real focus of my talk. And my particular interest here is in health literacy. And I've given you a definition of health literacy, which is highly unhealth literate. It's really complicated and clunky, but it is the one that everybody adopts, and so that's why I've got it here. It's so complicated, but it goes over 2 slides. But it's actually about people's ability to be able to get hold of, understand, and use information in order to promote their own health, their family's health, and their community's health, and take control. So obviously the bit that got me interested in this, that got me started, was about whether people could read the information I gave them and act on it. And that is important, of course it's important, but it is actually wider than that. Knowledge is power, and this is really partly a political argument about taking the power into the hands of people and communities, so that they are the ones who are in control of their health. And that sounds like sort of huge rhetoric, but actually that is the only sustainable way forward. Rather than continuing to try and patch up and deal with illness, we should be supporting people to take control and to develop their own health. So looking at the public health aspects of it, the population level. So we know from a huge amount of research that's been done largely in the US, but other places too, that people with lower health literacy have a bad time. They don't feel so well, so they have lower health, they have higher levels of illness, they have lifestyles that increase the risk of illness, and if they do have illness, they're more likely to find that limiting. There have been studies done in multiple industrialized countries, and in all of them, the consistent finding is that about half the population do not have the skills they need to be able to get hold of, understand, and use information for health. And I think that's just absolutely awesome in the size of the problem at a population level. So we decided we'd look to see if that was also true in England. So this is a study that I and these colleagues did, and it's going to be coming out in the British Journal of General Practice very soon. It's funded by MSD, so thank you for them. MSD is a pharmaceutical company, and they gave us an unrestricted grant to do this work, so thank you to them. And what we did was we took, we sampled a range of materials that people would need in order to become and stay healthy. So stuff about promoting good health, preventing illness, if you did get ill, how you managed it, finding your way around the health service, and the safety aspects. Did people know how to fit a car seat properly? Did they know how to find the right size cycle helmet? Those sorts of things. And we took that range of materials. We asked a group of experts whether they were typical of the sorts of materials in everyday use. They said they were. And we then used the National Skills, the BIS National Skills Survey from 2011 to look to see what proportion of the population had the skills to be able to understand and use that information. And we found that information fell into two groups. Some of it just had text in it, and some of it had numbers too. So if you look at those materials that just had text, 43%, sorry, the numbers have gone completely wild here. So for the national average, is 43%, and there is huge regional variations, for particularly for people who live in the middle of the English Channel. So basically, it's the usual picture. You have more people in the north of England who are facing more difficulties than people in the more affluent south, and then you have London as an island of deprivation in the south. And then if you bring in the numeracy aspect of it, because numeracy levels are really low, the pattern is the same, but the proportion of the population facing difficulties is much higher. And that figure of 66 should be lying over London. And this really hit me. You know, I thought, am I really, as a GP in South London, giving information out that 2/3 of my patients aren't going to be able to understand? What a waste of their time and what a waste of resources. And then if you start to bring this down to the person level as opposed to the population level. So these are the kinds of groups that you might see. And there are a couple of things I wanted to bring out here. The first is that people who are facing barriers to health from other things like job status, poverty, poor housing, etc. They are also a very high proportion, 3/4 of them, going to be facing problems with low health literacy. And there are going to be other groups within the population, like this kind of better paid, living in nicer houses, nicer areas, those sorts of things, for whom a far lower proportion are facing problems. But even so, 25% still have an issue. So it's a problem for everybody, but it's more of a problem for some groups than others. So that got me thinking about how does it feel from the other side of the doctor-patient relationship to be a patient with low health literacy. I know what it feels like from my side. It feels pretty comfy on the whole. But how does it feel to be on the other side if you've got low skills? And then how can I, as a doctor, how can my fellow health professionals start to respond to these challenges? So this is what the literature tells us. This is what my patients tell me when I talk with me about it, that I talk with them about it. The main thing is, if you remember back to the slide about health literacy and empowerment, low health literacy is disempowering. It's highly disempowering. People are struggling with very complex information. It's coming from multiple sources. They have to evaluate it. They have to feel, assess it and where it sits for them in their lives. They feel stigmatized when they try and tell somebody about it. These are often people who've spent their lives failing, having a tough time at school, having a tough time at work. And then they have this too. And also, they're likely to be coping with other barriers to health and well-being. And we've talked about what some of those would be. So what we can do about it, firstly, we have a responsibility as health professionals to do better, to ensure that health information is written better and that it's not only medically and nursing accurate, but also is at a level that people can understand and use. There's no point writing something that's beautiful and accurate but can't be understood. That's just a waste of time. We need to work to develop systems to share high quality information at different levels of complexity so that we tailor information. We already tailor it to people's clinical need. I wouldn't give someone with heart disease information about asthma unless they happen to also have asthma. So I tailor it to their clinical need already. Let's tailor it to their health literacy needs. I do, as was said, co-run the National Health Literacy Group. We've got a meeting on the 6th of March next year in Leeds, working with NHS England to actually do something about this and take it forward. My email address is at the end. Anyone who wants to come, let me know. So that moves it from the population level down to the patient level. But what I now want to talk about, which for me is the most exciting thing, is actually moving it from that and out into the community and thinking about health literacy in people. Because it's not enough to simply simplify and improve the health service. We've got to, at the same time, support the building of health literacy skills in individuals and communities. So that sounds like an obvious thing, but increasingly in these times of financial hardship, we have to be able to justify that. So here are some justifications from me. Health is important. People want to be well, they want their families to be well. So health courses, lifelong learning courses, community courses, focusing around health as a hook to get people engaged with learning is very attractive. It's something people want. Health literacy courses, and there's information around at the back, for instance, about the Excellent Skill for Health course, which was funded by the Department of Business Innovation and Skills and the Department of Health many years ago. And that's been evaluated, and that actually works. It builds health knowledge, it builds skills, it builds confidence. And it also supports social engagement and social networks, and it builds something. I've tried to avoid jargon, but I've stuck one bit of jargon in here, which I do think is important, which is that of distributed health literacy skills. So you look at building health literacy skills within communities, and that can be whatever's the relevant community for an individual. It could be their family, it could be their church, it could be their workplace, it could be their street. But if you build skills within communities, then that gives people extra resources that they could draw on, particularly if they have to deal with complex things at times that they feel vulnerable. And community learning is brilliant for doing that, and that has its own health benefits. Also, we know that the sorts of skills that people learn in health literacy courses are transferable to other areas of life. So I was talking with colleagues a bit earlier today about numeracy and how if you build, obviously numeracy is hugely important in health, people deciding whether or not to have a course of treatment, whether or not to be immunised, what the risks and benefits are of certain medical decisions for them. If they build numeracy skills there, they're going to be able to transfer that to other areas of their lives. They're more likely to be able to go on and get a job, and we saw some examples of that in the video, didn't we? People who got involved in learning, and that was a route into work for them. And work, of course, being in work is hugely health promoting. And there's the issue of power here as well, which I think is really important, which is that it supports people to take control over their own health, and that moves everything from an illness setting, which is the NHS, through to a health setting, which is everyday life. And that's not only better on a physiological, a sort of philosophical, is what I was trying to say, trying to get out from a medical paradigm. It's better on a philosophical level, but it's also the only sustainable way as money gets tighter, it's the only sustainable way to run a health system, is to have it actually moving out of the health area and into people's everyday lives. I would just echo what previous speakers have said about evaluating this. And this is something that I would say to the lifelong learning community. Just think about what you capture in terms of being able to prove that things have an effect. And the sorts of things that are routinely captured, what people achieve in terms of learning and skills, I think is incredibly valuable. But think about adding in things like economic measures of well-being, etc., because there are lots around. We're going to learn from the Centre of Wellbeing what the best ones are. And if we can add those in, then the health economists can do amazing things. If you can show that somebody's well-being score increases by 2 or 3 points, or their illness score decreases by 2 or 3 points, the health economists have some magic way of taking that and turning it into real money. And those are the sorts of that's the sort of evidence we need to take to funders to say, actually, community learning in general is important and is economically effective. And then within that, health literacy, community learning is also economically effective. So the last thing I wanted to say today was how important I think partnerships are. So I hope that I've made the argument that low health literacy is a real and serious public health issue that has a real impact on a large number of people. And I think the solutions lie in simultaneous approaches. So the health service has to step up to the plate. We have to do things better, and we have to provide services that are more in tune to people's skills and are tailored to individuals rather than a scattergun approach, hoping that some people are going to be able to do something with the information that we've given them. This is more about being responsive and tailoring. And that makes our information much more effective. But also at the same time, we have to build skills within communities. So I think there's a marriage made in heaven here, because health professionals have got clinical skills and knowledge. Also, we're going to have the skills to just know when people are running up against problems. So for instance, in a practice I used to work in South London, which is a very deprived area, the reception staff knew actually who had basic skills problems, and they would support them. So they'd fill their forms in for them, they'd send them text reminders that they had a hospital appointment. The community pharmacist would take them to one side and take longer to explain their medication. I, as a GP, can tell if a patient consistently doesn't take their medication properly or doesn't turn up to hospital appointments. So I know I can identify the sorts of people who will benefit from lifelong learning courses. And if I had a route to refer them in as a treatment, in the same way that you could refer people into IACT, for instance, that would be a good thing. And then you, as teachers and educators, know how to develop skills in individuals and communities. That's not a skill that I have. So that if you have good community skills courses in health literacy, then there may well be times when you want to bring, it would be helpful to bring a doctor or a nurse in to talk about specific medical aspects. But the actual building skills is a highly specialist skills, and that's best with people who know how to do it, like yourselves. And there are more opportunities now because of the way the NHS has been reorganised. Actually, local areas have the power to commission the services, the health services they think are right for the population they serve. There is absolutely no reason why a commissioning group couldn't decide to commission community education courses that are health promoting for the population they serve. So I would argue, go and talk to your local health commissioners and see whether they're open to that kind of flexible approach. So that's all I wanted to say. Thank you very much for your attention, and very